Well, we are still very well on time. So we may start the as the chairman, I have the prerogative of first question.
Always.
I don't really see why this technique, the first technique, is called tension-free, because there is, I didn't see in the technique any mobilization of subcutaneous and skin, subcutaneous tissues, and you just take out quite a big chunk of tissue from the midline. So there is, by definition, should be tension.
Yeah, the only difference with the classical method is that you give two stages of stitches. One is very deep, include the presacral fascia, and the other are in the subcutaneous, just to reduce the tension in the midline. And this, have you seen at the end of the procedure how the skin is just closed, and there is a reduced traction, because one of the problems when you give all the deep stitches, normally you have the traction, and in the post-operative course there is a descent of the wound. This is the small difference between the classical and these two different stitches.
Yeah. Okay. And, well, connected to this, the first question. The examples we have seen on the video and on the illustration taken from the papers deal with sinus with spinonidal disease, which is quite well localized to the midline. Okay, we see quite frequently one or more extensions, I would say, going to one of the buttocks. How would you deal with these cases? Are they amenable for the one of the closed techniques?
No
for
doubt,
the limber flap, yes, but
no doubts about the procedure. I use a limber flap because you can extend the excision, and you can have a bigger flap, just because otherwise the results are very bad. First of all, if you leave open, lay open, is you spend more than 2 weeks trying to healing the wound. With the Limburg transposition, is quite easy to have to achieve a healing after a week. This is my policy, and this is my result after more than 500 cases operated on.
Yes, I think you have to choose the right tool for the right patient. If it's a complicated disease with lateral sinuses and fistulas, and local excision is not enough, or it's not possible because you're going to leave a big open wound, then definitely you have to choose a flap, whether you bring it from the left buttock to the right side or from the right buttock to the left side. But it depends on the situation of the patient, and you cannot make general decisions without seeing the patient first and in the office, and then choose the surgical technique.
So what you are essentially saying that both techniques or any technique is legitimate. The question is really to tailor the right operation for the specific situation.
Correct.
I think that's part of the art and craft of surgery. You have to tailor it, the solution based on the situation of the patient and based on your abilities. Yes, if it's a simple sinus in the midline, then maybe a closed option or an open option, an open approach is fine. But if it's a more complicated situation or recurrent disease, then you may have to choose some other options.
Right. Any comments from the audience?
Just for the record, I don't think excision marsupialization operation exists. It cannot be either excision, and then you cannot do any more marsupialization, because marsupialization is to the edge of the open sinus. So just for the record, I mean, if you do a fistulotomy, and then you can do a marsupialization. Otherwise, it's not marsupialization.
So semantic problem.
Yeah, semantic.
So if you are talking semantics, in pilonidal disease, you shouldn't use actually the term of fistula. It's not a fistula, it's a sinus, by definition. And even in many health providers' computers, well, software, the diagnosis is spinonidal fistula, which is semantic mistake, isn't it? It should be a sinus. Ziv.
Spoke about the way of treatment, about the decision to operate a patient with pilonidal sinus 1. Would you operate on asymptomatic patient? 2. Would you operate on a patient who was treated for inflammatory process there with antibiotics and recovered? And would you operate on a patient who had the episode of incision and drainage of pilonidal abscess, and when?
Normally, when there is an abscess, the first step that I use is just to drain the abscess and to send the patients at home, because when there is a completely drainage, then you can consider for an operation or not, because sometimes it's enough just to give this just drainage to the patients, and the patients will heal. In case you have asymptomatic patients who had already 2 or 3 infections in the past, I think is a good idea to give an operation.
Yes, I agree. If you have a totally asymptomatic patient and you had like an incident finding of a midline pit, and the patient has no complaints whatsoever, I would not operate on that patient. I don't feel comfortable in operating on patients without any clinical symptoms. That's a basic rule. And the other option, if a patient had an abscess that was drained, yes, I would operate on that patient.
How do you see the asymptomatic patients? Because they usually go to a doctor if they have some sort of symptoms, at least pain, at least some inflammation, and maybe after a few weeks you will see them looking asymptomatic, just primary pits. So that's a good question, what to do in this situation. But they usually, you will see them after they had some symptoms. Not
cases that you can assess the perineum for hemorrhoids.
Okay, if it's an incidental finding, I wouldn't touch it. Well, I wouldn't touch it. Any other?
What about? I mean, the patient is symptomatic with pain. Pain is the symptom. No, and no infection.
No induration, nothing.
Yeah, he had some abscess in the past. He comes to you, it's all healed. You see some small openings, and you say it's very painful.
Normally, the pain depends on the inflammation. Normally, so this is what I think. Because why should be the pain without inflammation?
There is some.
Yoel.
I would be very
just a second.
I would be very careful operating on patients who had only pain. I would go through an extensive workup to rule out any other options for other pathologies in this region before deciding to operate. Personally, I have no experience with operating on patients with complaining on pain alone. But I would be very, very careful and go through an extensive workup, including an MRI of the area.
MRI of the sacrum and
yes, definitely yes.
Professor Engelbert.
I want to ask you about the post-operative treatment. Since we know that the nidus is the hair problem, how do you treat them post-operative about the hair? Do you recommend laser, let's say?
Yes, absolutely. I will recommend just to shave the field in the post-operative course, and then the definitive treatment with the laser, because normally the patients are hirsute patients, and one of the reasons for recurrence is just other pilots that we determine the recurrence, the high recurrence rate of the disease.
How long after surgery you recommend the laser?
Shaving the part for the first months, and then after 1 month, when it's completely healed, just the laser treatment.
Coming back to Micha Rabow's question about pain, in this case, I agree with Giovanni that there should be some inflammatory process there. I will give them for 2 weeks of antibiotics, and the pain resolves in most cases. The other issue is that in few months they come back with well-developed abscess sometimes, from time to time. But I wouldn't operate on pain, for pain, or even for presence of pits as an incidental signing, as we said. Any other comments?
To emphasize that one should always remind this patient that comes with he makes a diagnosis of a pilonidal sinus. It's not immediately an operation, because the result of the operation, as we have seen,
are not the best.
Not ideal.
So maybe sometimes it's better go with the pain than it goes with the recurrence, for which it will be for
Non-healing wound and months of business of wound caring.
I think you are right, but one of the you must emphasize that the wound should be not in the midline. Just we try to get an operation. It depends on Limburg or the excision, transverse excision, but trying to avoid to have the wound in the middle line, because this is the reason for the recurrence rate. Yes, we can shave ask the patient to be shaved to have the laser treatment, but the recurrence will be higher compared to other methods that they don't have the scar in the midline.
What about the Bascom techniques? Lots of literature.
I like very much.
It's a sort of minimally invasive.
Yes, it's minimally invasive. I have seen now in the last 2 months a Chinese surgeon just doing a little excision with the pylons and nothing else, and he reported a very good result.
Curettage of the sinuses.
Yes, just.
Well, we have here Dr. Weil is not here, isn't he? Is he Dr. Weil? No. They published. There's a group of colorectal surgeons from Asharon Hospital working in conjunction with quite a large military clinic. Many young surgeons suffer from pulmonary disease, even though we are a long time after the Korean War. Much less, yes. But they published a technique similar to Bascom's. They just take out, they just clean the tracks of the sinuses.
Yes, just cleaning.
With a brush, something like fistula drainage. And they leave it open, and I don't recall the exact technique, but they publish in thousands of cases, very large series, very good results. He promised me that he will be here to comment on this technique, but he isn't here. Any more comments, or we are still keeping the time, the schedule? Yeah, the last one.
Go ahead and you emphasize that you don't use a dye before surgery.
True.
One of the main reasons, face it or not, it's us. When we don't do the proper operation, then the patient will have a recurrence. Not every pilonidal is a simple, straight, fistulous sinus tract. Some of them are branched. How can you be sure that you take all the branches without using a dye?
Because I excise the tissue until I see healthy fat. I do not leave any unhealthy or questionable tissue inside.
I must agree with Dr. Eden, because if you obscure the dye, in most cases you just obscure everything in the area. And as a very experienced surgeon, you can differentiate because cellcy tissue and granulomatous unhealthy sinus. Do you inject dye when you deal with perianal fistulas as well?
Depends on the case.
Right, you don't.
Depends on the case, and Yoel, I knew I would get this answer, but if you inject the dye very slowly, not pushing all the amount of dye that you have in the syringe, then you are able to see the branch.
Okay, you can skid the cat.
But you can be sure when you finish the procedure, just if you open the tract, you can see if it's complete or not. Otherwise, with the methylene blue, you have a whole blue, and you don't understand nothing.
Yeah, but maybe sometimes when you want to be so sure that you take everything out, then you have a huge incision there.
Okay.
Too much.
We are just on time. Thank you.